Welcome, everyone, to the University of New Mexico Law and Mental Health Series, weekly discussions of practice and science featuring experts in behavioral health and the law. This is a series run by the Division of Forensic Behavioral Sciences of the University of New Mexico's Department of Psychiatry and Behavioral Sciences, in support with the New Mexico Behavioral Health Services Division. I'm Anthony Perilla, the Forensic Psychology Training Director here at the University of New Mexico. For our talk today, if you have any questions for our presenters, you can enter those in the Q&A box. You can enter those anytime you feel comfortable, but do know that we hold questions until the end, and oftentimes it's not possible for us to get to all of them. If you are pursuing continuing medical education credits, there will be a sign-in sheet posted in the chat box shortly that you can click on that link and sign up. I think it just popped up right now, in fact. If you are pursuing APA continuing education credits, there will also be a link that'll be posted in the chat box, but near the end of the presentation. So keep your eye on it near the end of the hour. Make sure you save that link or otherwise open it before the webinar closes so you have access to it. And make sure you save your certificate after you complete the survey because we don't have access to completed certificates after the fact. If you missed our most recent talk in the series, Dr. Jill Stinson's engaging discussion of interplay of ACEs, aggression, and suicidality for those involved in the forensic mental health system is now available on our YouTube channel. The recording for this week should be available on our YouTube channel as well later this week, and PowerPoint slides that, for those that have registered for the series, will be available later this week as well. As a heads up, next week we have Dr. Andrew Cecil who will be discussing forensic supervision from the supervisee's perspective. But circling back to this week, I would like to introduce you to today's speakers. We'll be discussing insights into violence risk assessment from a multidisciplinary treatment team perspective. Today we have Dr. Miguel Nuñez and Dr. Andrea Muschett. Dr. Miguel Nuñez obtained his PhD at the University of Cincinnati, where his work was supported by the National Science Foundation Graduate Research Fellowship Program and the University of Cincinnati Provost Fellowship. He completed a predoctoral internship and postdoctoral fellowship at the Alpert Medical School of Brown University. He recently joined the faculty at New Hampshire Hospital, Dartmouth-Hitchcock Medical Center, and the Geisel School of Medicine at Dartmouth College. While his work and interest is primarily on forensic mental health assessments and clinical interventions, he maintains an active role in research. Recently, his research endeavors have focused on mitigating patient-on-patient assaults and received support from the Awards of Innovation, Research, and Scholarship Program at Dartmouth. Dr. Andrea Muschett is Chief of Forensic Services at New Hampshire Hospital and a clinical assistant professor in the Department of Psychiatry at Dartmouth Geisel School of Medicine. She's been in the criminal justice, social human services, and forensic psychiatric arenas for the last 25 years in different capacities as a parole officer, a social worker, and a licensed psychologist. She developed and implemented the forensic program at New Hampshire Hospital, implemented the Booth Elopement Assessment Tool, the Acute Care Violence Assessment Tool hospital-wide to assist treatment teams to better manage patient risk factors, as well as piloting the Social Learning Program. She conducts forensic evaluations and consultations at New Hampshire Hospital and the Secure Psychiatric Unit at the Men's Prison for risk mitigation, treatment management interventions, as well as treatment planning. She actively participates in research on NGRIs and incompetent to stand trial populations, statutes and legal systems, elopement, stalking, models of care, and, as is prevalent for today, violence screening tools. So Miguel, Andrea, Dr. Nuñez, Dr. Muschett, on behalf of University of New Mexico, thank you so much for sharing your expertise with us today. I will go ahead and toss it over to you.
Thank you for having us. I'm going to go ahead and share our slides. So today we're going to be talking about information that we gathered from discussions with different multidisciplinary team members here at our state hospital in regards to their thoughts about the process and report of our violence risk assessments. But before we get started, a couple of stuff that we got to go over. Number one, if you're interested in receiving continuing education credits, please follow those steps. Neither Dr. Muschett or I have any financial disclosures to do as part of this presentation. And the views in this presentation are those of us and do not represent the views, policies, and positions of UNM or any of our affiliations. And one additional point, which is that 2 weeks ago, we attempted to present and we had a campus-wide outage of our internet. And so we deeply apologize for that. It was out of our control, but we're very sorry for any inconvenience it may have caused. And thank you for having us back.
Yes, thank you guys.
So in terms of learning objectives for today, we have three. Number one, we're going to be going over the purpose and process of a balanced risk assessment at a rural state psychiatric hospital. We'll then discuss the perspective that multidisciplinary team members have regarding the utility of balanced risk assessments. And then we'll use that information to discuss how we have been trying to effectively communicate the results of our balanced risk assessments to the multidisciplinary team here at the State Psychiatric Hospital. So starting off with the process, to give you some context, we are located in New Hampshire, which is a rural state with a total population of around 1.4 million people. Within the world of forensic psychology, a fun fact is that we are the one state that continues to utilize the Durham rule when it comes to criminal responsibility evaluations. And when it comes to state psychiatric hospitals, we only have one. This is it. And this state hospital has a total of 9 units with making up like a total of 185 beds.
And the way in which individuals come to New Hampshire Hospital is by involuntary emergency admissions or voluntary by guardian. And it's either if they have a gross inability to care for themselves, a danger to self, or a danger to others. As well as they do receive a probate petition if they reach that level. Once they're discharged from the hospital on a conditional discharge, and if somehow they do not follow that conditional discharge, then they get revoked and then they come back to the hospital. So those are the ways in which individuals enter our hospital.
And here, forensic services function as a consult model, meaning that we need to have an attending provider submit a request, either like a referral for a person. Now, historically, what we would do is once the referral was received, a forensic evaluator would then go meet with the attending provider to discuss the specifics as to the referral question, whether they were looking for us to help them develop a treatment plan or specific interventions during their hospitalization, whether they were looking for us to identify the readiness for discharge for a particular patient, or whether the patient was going to discharge and they were needing some assistance with their risk mitigation plan. And so historically, after sort of touching base with the attending provider, then we would conduct evaluation and develop the report. The report would then be sent over to the multidisciplinary team, and different team members of that, the different team members could suggest to the attending provider to request a balanced risk assessment, but it was ultimately up to the discretion of the attending provider to do so or not. And it is our understanding that decision-making ability was very much something that they utilize. So sometimes even when it was recommended by our team members, it was not submitted. Sometimes it was.
And so Dr. Nuñez and I kind of did a deep dive on the research in regards to violence risk assessment, which there's a lot of really good research out there. And the majority of the research focused on, predominantly which risk assessment tools are utilized, which we do, to make sure that we're also, paralleling the process, make sure we're updated on all of our research. And we found out that though it talks about risk assessment tools, risk mitigation, and it might say specific therapeutic interventions that are identified, but a lot of them or examples were not identified in some of them. And so we wanted to do a deeper dive in order to actually be specific and come up with risk management strategies, to make it more successful for the treatment team, for the patient and the outpatient provider, as well as society as a whole when they transition out.
So moving on to perspectives. So, as Dr. Perillo mentioned at the very beginning, like I recently joined the faculty here at Dartmouth, and as Dr. Muschett mentioned, when I came in, sort of one of the conversations that we had was, based on my training experience, like most of the recipients of my reports had been the court, not like a multidisciplinary team. And so I was very curious as to, what was their current perception of our balanced risk assessment process report. What did they find helpful? What did they not find helpful? And, sort of looking at the literature, like Dre mentioned, there is a lot on the risk management aspect or the risk assessment tools, but we didn't find much in regards to sort of the process of collaboration with these different team members. And so not having a lot of time, we to be able to do a full research project, we just set out to have discussions with our colleagues here at the state hospital to try to understand, what their thoughts were and try to utilize that information to improve the quality of our work. We wanted to make sure that, we really try to improve the process in any way, shape, or form that could be helpful to them, and also strengthen our report, or address any weaknesses that we may have, that they perceive that we have. So we went ahead and reached out to a total of 33 people across the hospital here. Those 33 people were comprised of 15 attending providers, which were made up of psychiatrists and advanced nurse practitioners, 13 social workers, and 5 rehabilitation staff, which were made up of occupational and recreational therapists. And as a forensic services team, we came together and sort of came up with a list of questions that we thought would help us answer the questions that we were sort of trying to capture. And those included asking them, when would you request a balanced risk assessment? Are you seeking particular information and or recommendations as part of the balanced risk assessment? What do you find most useful? What do you find least useful? And because we have no shame, we just kind of walked down to their offices, knocked on their door, and started asking them questions. We also had 2 additional questions. One, because we were curious as to whether people were reading the entire report or just specific recommendations, to sort of know whether, we should try to be more concise. Maybe they weren't reading it because it was too long, or maybe because, we wanted to highlight or strengthen certain sections, if that was what they were really sort of focusing on. Just to give you some context, at least my reports tend to be around 12 pages. So that was something that we were interested in capturing as well. And we had 1 additional question for social workers specifically, and that was to get an understanding of how often outpatient treatment team providers were requesting balanced risk assessments prior to a patient being discharged. And that was just to get a sense of how often it was being requested from our teams here at the hospital versus teams outside of the hospital. And so we, again, didn't do like a research project. It's not a research project by any way, shape, or form. I want to emphasize that part of it. So it was very informal. We sort of performed the questions with each of those people that we approached, and then we came together as a team and sort of started basically tallying the responses and separating them into 2 buckets: the more frequent responses and the less frequent responses. And so for question number 1, which was when would they request a balanced risk assessment, the more frequent responses were that if a patient had a history of making verbal threats of violence or made verbal threats of violence during their hospitalization, they would request a VRA. If the patient had a history of violent behavior and they didn't have a VRA before, or they showed violent behavior while they were hospitalized, they would request a VRA. And if they had a legal or criminal history, they would request a VRA. We had a couple of team members who sort of were more specific and sort of, sort of took it a step further and said, okay, they would only request it if the patient made threats towards the outpatient team specifically, or if the patient expressed homicidal ideation during the hospitalization, or if the patient had a high-profile criminal case. We also had a couple of other responses, such as some people who mentioned that they would request one if a patient was experiencing active symptoms of mania, or if a patient required to go through an administrative review committee for discharge, or to have the Attorney General be notified in order for them to be discharged. So those were the context in which they would request such balanced risk assessments. In terms of what particular information they were seeking, the more often responses that we received, perhaps unsurprisingly, were that they really wanted us to identify a level of risk, like a classification of risk, and they wanted us to identify recommendations to mitigate said risk based upon the referral question of whether they were seeking to do so during their hospitalization or upon discharge. In terms of less frequent responses, we had people mention that they wanted to, they were seeking to utilize the report as a second opinion, as a formal report to sort of back up the concerns that they had, or to sort of back up their decision that they had as they were sort of communicating with outpatient providers or with our administrative review committee or anyone else. We also had some people mention that they were specifically interested in our VRAs to identify the warning signs that a patient might be exhibiting whenever they are at a particular time where that depicts high risk for them to engage in violent behavior during their hospitalization. And we also had some people mention that they really like the report in the sense that, or they really seek in the report to look at our background section, because it sort of gathers all the relevant information for a patient into one single report rather than having it all in different pieces across their chart. And then lastly, we had some people who mentioned that they were very interested in looking at what the patient's perception was about their own behavior in the context of our VRAs. In terms of what they found most useful, the overwhelming response was the treatment recommendations. People really expressed that that was really what they tended to focus on a lot. We had some people who expressed that whenever we identified within a context of a patient being discharged, whenever we identified a level of care that met the needs or that could support the patient appropriately, that was always very much appreciated, and that if we could and that they found helpful whenever we provided specific examples about placements that meet the level of care that we identified. We also had a lot of people mention that the background section was particularly useful. They expressed the belief that psychology, forensic services had more access to records than they did. Just for some context, that's not entirely accurate. We have the same access to the same records. It's just that I believe that as part of our VRAs, we have to sort of examine a lot of the collateral records that are available, and so sometimes we're able to do that and express that succinctly in the report, and so it leads to this perception. They also really appreciated that we sort of cite where we are acquiring the information from, like being able to note where the sources of the data are coming from, so that if they ever need to utilize that information, they can quickly pull it up from the primary source. And also the violence stress level classification. In terms of less frequent responses, they mentioned that they tended to find it most useful whenever they're communicating with outpatient providers, and having had done a violence risk assessment to be able to express that to their providers and sort of collaborate with them to sort of establish a plan of care, as well as having a second opinion for the readiness for discharge for the patient. In terms of what they found, or they find least useful, the one consistent response that we received was that there were times in the past in which they perceived some of the recommendations to be very restrictive, and meaning that the way that they were worded or the way that they were expressed was were very specific, and that that could often lead to a barrier to discharge, because if we were making a very specific recommendation that they were unable to attain, that there were sometimes other community mental health centers or whoever the outpatient team was that were looking at this report had previously utilized the report to deny admission to patients. And so that was the most consistent response. In terms of less frequent responses, we had team members who expressed that oftentimes some of the recommendations can be predictable. So for example, like, optimizing medication regimen and like adherence to medication, for example, was one that they mentioned. They also expressed that the time that it takes for the evaluation to be completed and for them to receive the report it can be challenging, especially if they are trying to look at discharging the patient sometime soon. For context, we have a 10 business day turnaround for our violence risk assessments, our comprehensive ones, up to 10 business days. And the providers indicated that on average, they tend to have patients here between 5 and 10 days. And so they really would like for us to try to aim for 3 to 5 days, if at all possible, at least here. And so that was one of the things that they didn't find useful. They sometimes hesitated if they thought that it was not going to be able to, if it could potentially prolong the patient stay, and they didn't feel like it was an absolute need to have a VRA. We also had some team members express that the risk formulation was is not always very clear. They didn't often understand how it is that we arrived at the opinion that we did based upon just reading the report. And we also had some people who expressed disagreements about the risk factors that we utilized. Just for some context, we tend to utilize the ACR20 and the SAPRAF most often, and they sort of came into disagreement with they expressed some disagreement with some of those factors from their perception, from their perspective. Like we had specifically, I can remember we had one team member who questioned why we were looking at problems with employment as a risk factor for violence. And the other thing that was brought up that was not very useful or helpful was that not everyone was aware of there being a consult for a violence risk assessment. Right, so I think oftentimes we operated on the assumption that the team sort of communicates effectively with one another, and it's as we were told, like that's not. There are sometimes some breakdowns in that communication, and not everyone knows when there are additional resources being pulled to help a patient. And so they mentioned basically that it's not the evaluation, the report is not useful if they don't know that it's there to begin with. In terms of whether they read the entire report or specific sections, this is part of the reason as to why this probably wouldn't, one of the many reasons as to why this wouldn't fly as a proper research study, but it is because, but I think maybe they just couldn't say it to us since we were the ones asking the questions. But the overwhelming majority of them, 21 of them, said that said that they were reading the entire violence risk assessment, and 9 of them said that they were reading specific sections only, and 2 of them were honest enough to tell us that they were not reading it at all. And I think perhaps it is because of that, or because there's another reason, but we noticed during that conversation that there was some confusion as to how violence risk assessments are different from other risk assessments. The specific example that came up was that we had some team members who were expressing that the Department of Intellectual and Developmental Disabilities conducts a risk assessment in order for a person to be discharged into one of their placements. And that whenever they had tried to pass along our violence risk assessment, that they were not taking it, that they sort of sent their own person to do the risk assessment. And at first I was a little bit shocked. I said, why are they not taking our violence risk assessment? What are we doing that is subpar? And then whenever we sort of digged into it a bit more, it turned out that they call it a risk assessment, but it is a sort of an evaluation to identify the supports that a person needs when they are at their placement that has to have nothing to do with violence. And so there was some confusion within our treatment team in thinking that whenever there was any risk assessment, that equaled like a violence risk assessment, or that our violence risk assessment could cover any sort of requirement for any type of risk assessment. And then in regards to the last question, how often were outpatient teams requesting the VRA? We got a pretty big difference in terms of responses. We had some people say that it was from once a year to once a month. But what we did notice is that there was a difference in between the transitional housing programs and the mental health centers, with the transitional housing programs requesting it as often as half of the cases, versus the mental health centers who were requesting that at the most in 1/5 of the cases. All right, and then I'll turn it over to Dre for the sharing section.
All right. So in regards to capturing the referral question, right, what kind of dominates the whole report, and it's, for us to meet with the multiple team members, and I think we had like an internal assumption that the treatment team actually talks to each other. Miguel we figured out not all teams talk to each other. Not all teams are created equal in their communication skills. And some of the treatment team members weren't even aware of what a violence risk assessment was. I can give one of the rehab staff that I had talked to, she had never really seen one before, but when I showed her one and explained it to her, she really liked it and wanted to see more. And now I'm going to be doing a training in the rehab department in order to show them kind of the ins and the outs of a risk assessment and just kind of the comprehensive way in which we write it. And so we were able to help describe and show what it was for. And another thing too is regarding collecting collateral information, is to meet, with each team member to, get their perspective. I mean, though we can read their notes in the chart, but we want to talk to them kind of one-on-one and see, what their thoughts are, what their feelings are in regards to the patient, objectively, because not every single conversation enters the chart, fortunately and unfortunately, but it is able, and then also in regards to the outpatient team requesting a violence risk assessment, because for example, the social worker will say, oh, well, we need a violence risk assessment. The provider might not know that because it was the outpatient team that actually requested it. So it's kind of trying to connect the dots in the loop in order for everyone to understand what's going on, because technically the provider has to put in the order for the risk assessment to be done. So this is just kind of helping connect the dots of communication within the treatment team itself. In regards to after we're done doing the report, is to then sit down with the treatment team and, go over it with them and highlight all the work that they've done, with the patient, and how we review the progress notes and any other evaluations that had occurred either during the hospitalization or prior to, if they had a neuropsych evaluation done or any psychological testing done. We incorporate that into our report, or competency evaluations or independent psychiatric evaluations as well. We help describe to them the risk formulation and how we, outweighed the risk and protective factors, what we considered, what we didn't, and why, per research. And we all know are like our high risk factors. And then again, to how that is directly related, and it comes back full circle to the referral question. And then we help describe the risk management plan to them. And so what we did is we provide them a chart to help them go through how we describe our risk management plan. So this is an overwhelming risk management plan, but these are multiple examples in one. We don't give something like this to them, but I just wanted to give you guys a visual representation that I can help kind of walk it through. For example, when we're describing it to the team, we're saying, Mr. So-and-so has schizophrenia. So therefore, kind of what would that look like with psychiatric medication? If we have an individual that's been in the hospital multiple times for medication and treatment, non-adherence, what does that look like? At that point, especially if there's a violence history, or criminal history or whatnot, we're more likely to recommend a long-acting injectable to help with the continued adherence to the medication. As well as, working with the treatment team, while they're inpatient, having them maybe transfer from an oral to a long-acting injectable, and then having the direct care staff observe their behavior, how are they doing with their supervision status? Are they able to, are they restricted to the unit? Can we progress them through the system? How are they progressing through the hospital system as an unit restriction, escort and building, to we have some patients that are able to go on community trips with staff as well, to see how well they're clinically and behaviorally stabilized, and how they're doing within groups. And so we, let the treatment team know when we're going over the risk assessment is, they attended these groups, they've learned these skills, they've been able to apply these skills that you've taught them, they're engaging with you as a treatment team. And so this is what's helpful while they're in the hospital to help them get them engaged, to help prepare them for, possible outpatient treatment. And then we also have other, if they come in with substance abuse, we can recommend a consult service with our substance abuse team here. We have different substance abuse groups or individual LADAC therapists specifically for them. And then another example would be if the patient, is stabilized within the hospital, and if their risk assessment was specific to interventions in the hospital with the groups and how well they're doing and decrease in violent behavior. And then the treatment team could request another risk assessment, or the majority of the risk assessments that are requested are for transitioning back out into the community. And so then we're able to, use how well they're doing in the hospital, and can that be mirrored outpatient? And work with a community mental health, with the social worker to see, what community are they going to? Are they able to receive assertive community treatment services, with wraparound services with medication monitoring, management, functional assistance? What level of supervision do they need? Are they ones that can live independently? Do they need to live in a group home type setting or transitional housing? And again, a lot of that stuff mirrors in the community of what we would then recommend and what we explain to the treatment team, that they would need further substance abuse treatment and whatnot, or possibly urine drug screens, and depending on if they live with family or where they live. And the next slide, this is in regards to if there's specific risk factors such as homicidal ideation, or if they're displaying very aggressive and assaultive behaviors in the hospital, and how can we help them mitigate that risk while they're in the hospital, through the risk assessment, through a risk formulation plan, whether it's through medication supervision, and to help do safety plans for them. And also, going to guesstimate on the percentage, 25% possibly, can come in the hospital that have access to weapons or not. And not that might not have been the cause of their admission, but we also want to make sure, depending on what their level of clinical stability is, behavioral stability, is there access to weapons? Is there not access to weapons? Does there need to be a safety plan implemented, if they are going back home and there are weapons at the home? Are they going to be stored separately in a safe and the ammo stored separately or not? Is whomever who's going to be in charge of that, to make sure that we are mitigating the risk as much as possible. I also put here, in the majority of the states in the US have the federal mandate that most states follow, is if they are been adjudicated as a mental defective or committed to any mental institution, then they are put on the NICS list. Well, through that, there are 4 states that do not utilize this, and their states have not implemented that, and New Hampshire is one of them, unfortunately. We've been trying to go to legislation to try to change that, but we are unsuccessful at that, unfortunately. But that's just food for thought, because most states do. I believe it's New Hampshire, Alaska, Montana, and Wyoming are the states that did not adopt this. And the other things that internally we can do if we need to recommend to the providers, depending on the referral question, is we have what we call is HEM 306, which is medication against objection here in New Hampshire. And it's a 45-day, it's allowed for 45 days if we receive it. And it can only happen twice in one hospitalization. or if it rises to the fact that we need to get a guardian or not, depending on the person and the situation and all factors that be, if that would help mitigate any risk whatsoever or not. And sometimes we received them from the House of Corrections, or that's what they call it in New Hampshire, it's jail. Or are they going to be transferred back to House of Corrections, and what does that look like? Sometimes we get them from jail, we stabilize them, then we send them back. And if we have a patient that reaches the level of violent threat, assaultive behaviors, and we're unable to manage them within our hospital, then we transfer them to the secured psychiatric at the men's prison. And another example we give, and we try to make sure that it parallels the process within our risk management plan, is if we do have an individual that has bail orders, domestic violence orders, no contact orders, that we make sure, that the patient has a copy of them. It's amazing how many patients don't have a copy of these. So we try to get the patient's copy of any orders that they have. So that they're aware, and then process it through them with them of saying, like, are you aware of this? And what does that look like? Like if you have somebody who has homicidal ideation and they have a no contact order or stalking order petition that they're not allowed to have contact with, and they're still trying to have contact with it. Okay, well, they're not ready for discharge if that's the case, and how else can we mitigate that risk as we're trying to explain this to the treatment team. So another theme that came out of our kind of quality assurance that we did with our with the multidisciplinary teams was like what they would find more helpful or not. I mean, obviously we're an unbiased party and we're going to do what we need to do, but it was nice to receive their feedback. Their theme was they didn't want to feel pigeonholed. So if we say a specific type of treatment or a specific place, that if that, I don't know about your guys' states, but our state's very limited resources to where they reside or not. So therefore, we can't say, oh, go to this specific transitional housing program. We might, broadly say transitional housing program and not say the actual name of the transitional housing program, or group home with wraparound services. So the goal is obviously not to pigeonhole them, into one specific thing, or like different treatment approaches, or the type of person who's going to give that treatment. Like if we say, individual therapy, from a psychologist, but yet the outpatient treatment team psychologist is on backlog for 6 months, then the outpatient team will be like, oh, well, I'm sorry, we're not allowed, or we're not able to accommodate, that recommendation. So the patient we're not going to accept them for, to come to our treatment. And so obviously we're not going to say that, but we're going to, do a broad stroke and say specific, clinician, in any license, whether it's a social worker, mental health counselor, or psychologist that could provide the counseling. And then we try to avoid words like must and shall, which when I was in the Texas system, we did violence risk assessment, which I know Miguel has done too. Like you're so used to using must and shall because we're so used to more court documented risk assessments. And here it's more like may benefit from, this particular theme, or the treatment team could consider if we're doing one for inpatient. Because if not, that again could possibly, pigeonhole either the transition out if we say must or shall. So we have a couple examples on the next few slides. So for community transition, we can say based on, Mr. So-and-so's mental health needs, he is likely to benefit from stepping down to transitional housing program. And then we can say, for example, NFI transitional housing offers 24 monitoring supervision, in addition, NFI treatment services include, medication management, individual and group therapies, functional support services, or rehab services. We can expound on that, but again, it's just an example, and they would likely benefit from that. Versus, saying needs to be placed at specifically NFI, right? So we try to avoid that. Another one for community transition is, give the example of how they participated in psychotherapy sessions while they're in the hospital, focus on managing their anger, and basically saying when they return to the community that they would benefit from continuing to work on developing and implementing, their coping skills with a licensed mental health clinician, versus saying that if they return to the community, they must continue to work on developing strategies with a licensed psychologist, right? So we want to keep it a little broad on who is going to provide those services, to understand the environment and where the person is going, and understand the community limitations as well and the resources. Another thing too that we explored in regards to the report, which we continue to do, is we found out, as Miguel had referenced, the sources of information. They really like how wherever we found it, because somehow, they might not have a chance to do a deep dive like we do. So we're able to identify, according to this report, dated on this date, this is where this information came from, and try to do like a timeline if we can. Depending on the referral question, of course, and also with the risk formulation section. And one of the comments from one of the treatment team members was that we had predictable recommendations, as in, well, we know you're going to say they need medication. We know you're going to say that they need, substance abuse treatment. True, and very true statement. We agreed with them 100%. However, it's at what interval and how are they going to receive that? Like, do they need a long-acting injectable? Do they need medication management and supervision, right? That takes it to a whole nother level depending on where they're at in their treatment and their clinical stability. Like, for example, if we have an individual that's going to transition back home and mom is the caretaker, and unfortunately he has assaulted mom quite a few times. And so we're going to try to not have mom be the medication giver, right? We're going to see if maybe ACT level services can be provided in the home, and they can do the medication management and supervision, right? To kind of take the mom out of the picture to make sure that that helps decrease and mitigate the risk of violence. And so another example would be, while hospitalized, about how Mr. and Mrs. May benefit from consistent participation in individual therapy, aimed at developing adaptive coping strategies and managing distress associated with symptoms of psychosis. And, then we would recommend a referral be put into the psychology department here. And then also, if it's a specific type of therapy, we have a good handful of really good clinicians here, and we can maybe, ask them like, hey, would you be interested in providing this specific type of therapy for this patient? So we're able to, kind of adapt, what type of therapy or intervention that the patient is needed, versus saying, Mr. X should be referred to individual psychotherapy, just aimed at that. But we're able to be selective at who and what, and then also tailor it towards the environment and the practitioner. And another example is, given the patient's history of opioid use, the treatment team could consider a consultation with addiction services, here at the hospital, to explore the appropriateness of, possible medication-assisted therapy. Because obviously that's not our specialty as psychologists. Maybe some of y'all's, I know in different states, people can get certified in it or licensed in it, but that's, we're going to say that they would benefit from a consult, and we will let that, person's expertise then have another, recommendation on if, the patient does benefit from MAT or not. So that's really helpful to have that extra service here at the hospital, versus saying that they'd benefit versus us just straight up saying they'd benefit from MAT, because we know we stay in our lane, but not our lane. So these are some of the examples, that we have. And another one with community transition. We run into this probably more often than we'd like. If we have a patient that has a history of diverting medication, we can say that the outpatient treatment team may consider periodic blood draws to measure and track the therapeutic, blood levels of the medication as well. And then versus saying, that should be discharged to an outpatient team that will periodically do it. Because there's some outpatient teams that aren't able to do it depending on what encatchment area they go to. Some of them do not have a lot of those services. And then as we know, if people are not taking their medications, and we would know that their therapeutic drug levels they're not able to be managed. So, they're more likely to decompensate quickly if we're unable to do so. So looks like we were able to finish, so we can answer any questions.
Well, thank you so much, Dre, Miguel, Dr. Muschett, Dr. Nuñez, on that very helpful talk, including some practical specific examples that can help us visualize how to communicate some of these findings and the balance of, for me, it's always the difference between providing the information that other service providers need to do their job versus telling people how to do their job, and kind of that fine line of the specifics of recommendations. So being able to visualize it, I think is very helpful for a lot of the audience, and thank you for that. The CE link should be up fairly shortly. In the meantime, if you have any other additional questions for our presenters, feel free to enter them in the Q&A box. I'll go ahead and address some of those questions here for them. And in the meantime, if you have more questions, feel free to ask away. Someone asked about how far you go in terms of being accepting of or acknowledging community limitations and recommendations. So if, for example, you think an individual needs to be seen by a therapist who specializes in autism for the court, and the court says they don't know of any, does it not take away from the weight of your opinion if you say it's okay to just find any alternative?
Definitely a fine line. We can say that it, be beneficial, to have a specific therapist if available. If not, maybe identify other types of therapy that could help depending on the behaviors in which the patient is demonstrating or not. So if there's something very specific, then maybe somebody that specializes in other things or might have other concentrations. But I mean, we put it out there as they would benefit from, however, try to help them come up with an alternative. There's been so many times I've researched on the web, even in our little town here, and some of the social workers or outpatient providers are unaware of even our local resources, to give them examples.
Wonderful. Thank you for that. Someone said in Minnesota, often the patient will be discharged with a stay of commitment, such that if the patient does not follow recommendations for the safety plan, then they'll be recommitted to the hospital. From your understanding, how often does this happen in other states? Or at least in your state?
Okay, I'm like, other states, not quite sure. In our states, it's more likely than not, we have individuals that come back in and they get revoked on their conditional discharge, which sounds like similar to their what they were saying, because they're not following their stipulations of not taking their medications, or abusing substances or somehow being violent. And so then therefore their conditional discharge is revoked and then they come back in the hospital.
Right. Going back to this kind of these recommendations and the fine line of how much to recommend, and somebody asked, what if being vague is harmful? For example, if attorneys don't know the mental health system like providers do, and the ambiguity leads to them not referring at all or the wrong service. I guess the question is, how do we balance this in a way that attorneys will know what they can or should do without going so far as saying you must or shall do this?
We like using a lot of examples too. Saying Muschett would benefit from, but an example would be like one of the slides I said, like, could transition to NFI, transitional housing program, so we can give an example of what they could explore, or give them there's different lists too, or different group homes or different other agency supports so that they have that. So we could kind of maybe start broad and do certain individual things if need be, depending on the situation on a case by case basis.
Great.
I'm going to add something to that response. I'm going to say that, within the stuff that we discussed today, it is within the context of the treatment team here at the state hospital requesting the violence risk assessment. So the recipient of our reports will not necessarily be the attorneys. In fact, there are individuals who don't have, or who are not here for, because they have an attorney, or they don't have legal charge or criminal history, So some of these recommendations, or some of the way that we're wording things, are specifically because we're trying to communicate more effectively with the treatment team rather than to try to express them and explain them to an attorney. I think, there, of course, there would likely be differences if if the recipient of your report is going to be the court, right? I think that the way that we sort of frame the balance sheet is going to be different.
Certainly. Thank you for that. We have had a couple of people that are asking if you could share the QR code again, so that while we're discussing these, they can scan that. In the meantime, a bit more of a zoom out question. Somebody's asking, in general, how predictive are violence risk assessments of short-term future violence? Which is a lot of what, commitment, of course, tends to focus on, as opposed to more of these long-term violence risk assessments that we use.
No, Miguel wasn't sure if he was going to start talking or not. No.
Yeah, you can take it.
Okay. And if I'm understanding it, like as in inpatient, like as if they're inpatient, we're helping out with like interventions while inpatient, or
I think you could focus on that. I think they're getting at the idea of, when we use these risk assessments, most of the time when we think of the existing violence risk assessment tools, they tend to focus more on long-term outcomes. And I think this person, because a lot of commitments focused on acute violence, how predictive are risk assessment measures for more of this immediate future violence?
Yeah, we as Miguel stated earlier, we use the HCR20 to help, go through what does that look like inpatient, plus the historical factors, and the current clinical factors, and still base it off of that, how high, what is, their categorical risk factors, while inpatient or not. And so we're able to break it down, especially with a lot of the behavioral observation and the most recent admission, to how we can continue to, mitigate and help out the treatment teams for that, to create specific interventions while inpatient. I don't know if that was kind of a roundabout answer.
Sure. Fair enough. Thank you. Someone asked if you consider trauma history and how it might be manifested in either the behaviors, the person's interactive style, or their treatment progress, how trauma gets considered in these.
Yes, it does get considered, specifically if we're, talking with the treatment provider or the clinician who's seeing them for therapy, possibly, to see, are there specific triggers or different things, so that we can identify that and have that as, protective factor of how what is their insight in regards to their trauma history? Do they know their triggers? And what other therapeutic interventions can help continue to tailor to help them with that, as well as, is there any specific interventions that we could find out in the community to help continue to target that?
I know near the end of the presentation, you referenced treatment teams in terms of, perhaps some frustration or the caveat of like these more expected conclusions or things that came up to them as they would say fairly obvious or so. On the flip side of it, somebody asked, how do you navigate treatment teams expressing frustration, if expressing frustration at all, with new or unexpected risk considerations? Their example is the treatment team previously conceptualized bipolar disorder. You're framing things in terms of psychopathy. And now this completely new focus is brought to their attention. How do you navigate that?
We love meetings. We love having meetings, and we meet with the treatment team, and we just say what we found and how we came up with, the data, in which we're like, okay, psychosis because of this, or the clear history because of this, and the pattern of behavior in which, we saw get brought up, and tried to, and, work collaboratively with them, right? Because it could be it's a tightrope sometimes, depending on the provider and who it is. But to be able to say, this is where we received our data, this is our objective information, and this is how we came to this conclusion. And then see if they're like, oh, I didn't think of that, or I didn't have that information. It's amazing how much, once you're finally all in the room, they're like, oh, we didn't even know that. And we're like, oh, they're like, well, that will change our perspective too, or maybe not. And sometimes, we can agree to disagree, but we just go based on our, training and our education and our knowledge with all the objective data that we have to our conclusion.
Wonderful. And I see Miguel's able to type away at some of the more side questions that some people have been able to ask, and he's addressing those on the side. And thank you for that, Miguel, since as you've seen, quite a few questions here. As we get near the top of the hour, I'll ask one final question here. The person first of all set up awesome presentation, and then said, out of curiosity, if you were to perform this informal study again, would you do anything differently? I'm thinking about it. If I wanted to coordinate with my teams at my workplace, it would be helpful to hear what made the process easier or more difficult.
I love doing oh, go ahead, Mike.
No, you can go first. You can go first. So go ahead.
I know obviously we're the one, we probably shouldn't have been the ones asking the questions, but that's sometimes the only way to get it done, because if you send out a survey monkey, nobody answers it. But if you corner them in their office, not really, but kind of, and say, hey, I have a couple questions for you. And, and that's how we were able to get in. Our colleague, Jennifer Mara Cox, is on here too. And she helped do the same thing. Just like, hey, do you have a couple minutes? Because everyone is super busy, and we're debating, we're like, maybe we could send out a survey monkey, maybe they'll do it. And in our experience for other like committees I'm on, we try to send out survey monkeys just for times, and nobody even answers those. So we knew if we saw them face to face that they can't avoid us, so. But we would love to, Miguel and I were talking about that too, is like, how could we actually do this, to do a like legit study, not just more quality assurance. So.
Understandable.
Miguel?
Throw it out. Yeah, Miguel, if you had any thoughts there.
I think, part of it is we had a very biased sample, right? The people that we approach, we know them, and it was a matter of like who was available at the time that we sort of went out. So there was no randomness to it. It was a very biased sample. The questions that we sort of came up with were, sort of open-ended and qualitative, but we didn't actually do any like analysis of that information to actually, sort of be able to identify themes, like patterns, in a formal way, right? We also, like, there is some differences in terms of who was represented, right? Like on the people that we had in the people that we approach, right? So ideally we would want to be able to capture other fields as well. Like we didn't get to approach nursing, for example, right? We didn't get to approach mental health workers. And it's interesting because when it comes to the risk mitigation plans or the treatment plans within the hospital, the people who are often sort of being the front line are those mental health workers, the nursing, right? And so it's really important, at least in my opinion, to sort of incorporate them into this process. And so that's something that I think we also missed.
Wonderful. Well, thank you so much, Dr. Nuñez, Dr. Muschett, for all the work you were doing on this and translating it in a way that is digestible for a lot of providers out of here. Your work in this area is very, very much appreciated. And thank you for sharing all of that with us. And that wraps up this week's Law and Mental Health series. Next week, we have Dr. Andrew Cecil, who'll be discussing forensic supervision from the supervisee's perspective. We hope to see you then for another great discussion of issues in behavioral health and the law. Until next time.
Thank you.
Thank you, guys.